Hello and welcome. If the C810 OA exam has been on your mind and you're wondering how to approach it, then you're in the right place. Our website has C810 OA questions and answers, and it won't cost you a thing. OA exams are tough, so everything from guides to practice questions is free. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. In this video, we will cover questions from information governance, data quality, clinical documentation, health IT, disaster continuity. So, let's get started.
Question 1. A hospital is building a structured approach to manage and optimize organizational information for both current and future regulatory, legal, risk, environmental, and operational needs. Which formal framework relies on policies, procedures, and multidisciplinary arrangements to govern information output across systems? Your options are A. Data architecture, B. Records management program, C. Information governance, D. Master data management. Which one is it? Pause the video if you need more time. The correct answer is C. Information governance. C is correct because information governance uses formal policies, procedures, and multidisciplinary arrangements to manage information output across organizational systems and to address current and future regulatory, legal, risk, and operational requirements. A is wrong because data architecture provides specifications used to describe existing state, define data requirements, and guide integration, focusing on technical data input rather than the broader governance of information output across systems. B is wrong because a records management program handles record retention, storage, and destruction processes for individual records but does not address the broader governance of organizational information, output systems, and overall enterprise strategy. D is wrong because master data management focuses on enterprise key business entities such as customers, employees, or patients, not the broader governance of information output policies, procedures, and systems across the entire organization. Let's go deeper on information governance and why it exists as its own discipline in healthcare. Information governance is the formal framework sitting above every system that touches patient information. It decides how data is created, protected, shared, retained, and destroyed. HIPAA formalized it for healthcare in 2014 because electronic records had shattered the old one chart per patient model. Information governance is easy to confuse with three related disciplines. Data architecture is the technical blueprint. Records management handles retention and destruction. Master data management standardizes key entities like patient and provider identifiers. Information governance sits above all three and sets the policies they operate under. On the exam, watch for signal words like enterprise-wide, multidisciplinary, and policies and procedures. If the question describes a narrow discipline, pick a sub-discipline. If it describes the whole structure holding everything together, information governance is your answer. Think of information governance as the traffic cop for the entire enterprise. When the question asks who is in charge of everything at once, that is your answer. Question 2. A chief information officer at a regional hospital takes direct responsibility for overseeing the data breach response, auditing electronic records, and supervising the management of all information assets across the entire healthcare organization. Which information governance principle does this scenario most directly illustrate? Your options are accountability, B. Transparency, C. Protection, D. Compliance. Take a second. Which answer would you pick? The correct answer is A. Accountability. A is correct because accountability assigns a senior leader, such as the CIO, the formal duty to oversee the IG program, answer for breach response, audit records, and manage information assets across the organization. B is wrong because transparency focuses on documenting and disclosing IG processes openly to reduce mistrust and miscommunication, not on assigning a senior leader to oversee asset management or breach response activities across the organization environment. C is wrong because protection focuses on safeguarding information from breach, corruption, and loss through technical controls and policies rather than on placing leadership oversight responsibility for information assets in a single executive leadership role. D is wrong because compliance focuses on meeting laws, regulations, accreditation standards, and organizational policies, not on the senior leadership oversight role assigned to a CIO managing critical organizational information assets across the enterprise. Let's dig into why accountability sits at the top of every information governance framework in healthcare. Accountability means a single senior executive, not a committee, owns the entire information governance program. Distributed ownership produces no ownership. So one named leader carries the authority and the formal duty to answer for what happens to the organization's data. Accountability sits above the other 7 HIPAA principles: protection, compliance, availability, retention, disposition, integrity, and transparency all describe what the program does. Accountability describes who owns it. In practice, the accountable executive does 4 things: oversees governance policies on a regular review cycle, chairs the cross-functional steering committee, owns breach response and the notification clock, and reports metrics directly up to the board. When a question names a chief information officer or chief privacy officer owning something organization-wide, the answer is accountability. Other principles describe tasks. Accountability describes the person responsible for making sure every task gets done. Question 3. A hospital recently discovered unauthorized access attempts targeting confidential patient records stored in the electronic health record system. Leadership has launched an organizational initiative to strengthen safeguards against breaches, corruption, and loss. Which information governance principle is being emphasized in this response? Your options are A. Availability, B. Integrity, C. Compliance, D. Protection. Before I reveal it, which one do you think is right? The correct answer is D. Protection. D is correct because the protection principle directs the IG program to provide appropriate levels of safeguarding for information against breach, corruption, and loss, which directly matches the goal of this organizational security initiative. A is wrong because availability addresses keeping information accessible and retrievable when needed for clinical and business use, not strengthening safeguards against unauthorized access, corruption, or loss of confidential patient data records stored in the system. B is wrong because integrity focuses on the authenticity and reliability of generated information rather than on the active organizational safeguards put in place to defend records against unauthorized external access attempts and security breaches. C is wrong because compliance addresses adherence to laws, regulations, standards, and organizational policies, not the implementation of organizational safeguards designed to defend information assets against unauthorized access, attempts, and patient data security breaches. Let's go deeper into the protection principle because it's the one that actually stops attacks from happening. Protection is the active work of building defenses. It's not knowing the rules, it's the walls, locks, and alarms that keep threats out in the first place. The HIPAA security rule formalized protection into 3 categories: administrative, physical, and technical safeguards. A mature program covers all 3 because gaps in any one layer can undo the others. Here's the nuance exam writers love. Compliance is the document saying multi-factor authentication should be enabled. Protection is the MFA that actually blocks the attacker at the login screen. When a question describes safeguards, preventing unauthorized access, or defending against a specific threat, the answer is protection, not compliance, not integrity, not availability. Question 4. A health information manager is reviewing inactive patient records that have surpassed the legally mandated retention period and is now preparing them for secure shredding so they cannot be reconstructed by anyone after destruction. Which governance principle directly applies here? Your options are A. Retention, B. Disposition, C. Availability, D. Integrity. What's your answer? Commit to one before I continue. The correct answer is B. Disposition. B is correct because disposition addresses providing secure and appropriate disposal of information no longer required by applicable laws or organizational policies, which matches the secure shredding of records past their required retention period. A is wrong because retention covers maintaining information for an appropriate time based on legal, regulatory, fiscal, and operational needs, not the secure destruction process that follows after the retention period has expired at the organization. C is wrong because availability concerns timely and accurate retrieval of information when it is needed by authorized users, not the secure destruction of records that no longer need to be kept by the organization at the facility. D is wrong because integrity addresses the authenticity and reliability of information generated and managed by the organization, not the secure shredding of records that have already met all required legal retention thresholds at the facility. Let's zoom out and look at where disposition fits in the bigger picture of the record's life cycle. Retention and disposition are twin principles covering opposite ends of the same life cycle. Retention keeps records for the legally required period. Disposition destroys them cleanly, irreversibly once that period ends. A record moves through creation, active use, and archival storage. Once the retention clock runs out, it crosses into disposition, the final irreversible stage. Proper disposition has strict requirements. Paper is cross-cut, shredded, or incinerated. Digital media is cryptographically erased, degaussed, or physically destroyed. And every action is captured in a destruction log proving what was destroyed, when, and by whom. On the exam, keeping records means retention. Permanent, verified destruction after retention expires means disposition. Same life cycle, two different moments. Question 5. A health information director and a chief information officer are revising the data governance strategic plan to standardize data language across the system and to make sure all data regulations, accreditation standards, and federal mandates are properly met. Which governance principle drives this initiative? Your options are A. Accountability, B. Transparency, C. Compliance, D. Availability. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Compliance. C is correct because compliance directs the IG program to follow applicable laws, regulations, accreditation standards, and organizational policies, which directly matches meeting data regulations and federal mandates in the strategic plan. A is wrong because accountability assigns oversight responsibility to a senior leader for the IG program, rather than focusing on the organizational effort of meeting external regulations, accreditation standards, and federal mandates across systems. B is wrong because transparency requires documenting IG processes openly and verifiably to reduce mistrust, not the organizational act of meeting external regulatory requirements or aligning the strategic plan with applicable federal data mandates. D is wrong because availability covers timely and accurate retrieval of information when needed by authorized users, not the alignment of governance strategic plans with external regulations, accreditation standards, and applicable federal data mandates. Let's dig into compliance, the information governance principle that aligns your program with the outside world's rulebook. Compliance is the work of meeting every rule that applies to your organization. That includes federal laws like HIPAA and HITECH, state statutes, accreditation standards from bodies like the Joint Commission, and the organization's own internal policies. In healthcare, this rulebook is dense and constantly changing. The mechanism of compliance is the control framework. Each requirement gets mapped to a specific control, a safeguard designed to satisfy it. Controls are documented, tested, and evidenced. You don't prove compliance by claiming it. You prove it with training records, audit logs, and risk assessments when the surveyor arrives. Think of compliance as passing inspection. The rulebook is written by someone else, and when the inspector shows up, your job is to produce the evidence that every rule was followed. So on the exam, if the question names a regulation, a federal mandate, or an accreditation body, the answer is compliance. Accountability is internal ownership. Compliance is external alignment with the rules. Question 6. A health information director is selecting an organizational framework that defines acceptable levels of data quality and continuously verifies the organization is meeting those defined levels in order to support clinical decision-making and ongoing business operations. Which HIPAA framework applies here? Your options are A. Data quality management, B. Data stewardship program, C. Master data management, D. Data architecture model. Which would you go with? Lock it in before the reveal. The correct answer is A. Data quality management. A is correct because data quality management is a continuous process for setting acceptable parameters of data quality and verifying that the organization meets those defined levels to support business and clinical decision needs. B is wrong because data stewardship assigns individual responsibility and accountability for data within a specific domain across its life cycle, not the continuous organization-wide framework for setting and verifying acceptable data quality levels. C is wrong because master data management focuses on enterprise key business entities such as customers, employees, and patients, rather than continuously defining and verifying acceptable levels of data quality across the entire organization. D is wrong because data architecture provides specifications used to describe existing state and guide data integration across the enterprise, not a continuous process for setting and verifying acceptable data quality levels through defined parameters. Let's look at the framework behind this question. Data quality management as defined by HIPAA. Data quality management isn't a one-time audit or a periodic cleanup. It's an ongoing cycle where the organization sets quality parameters, measures performance against them, closes gaps, and then measures again. The cycle never stops because quality isn't a state, it's a discipline. Here's the cycle in practice. The organization defines parameters for each data domain, measures current performance against those thresholds, identifies gaps, drives improvement, and then measures again. Continuously. Don't confuse data quality management with its neighbors. Stewardship assigns accountability for a domain. Master data management standardizes key entities like patient identifiers. Architecture defines structure. Data quality management works across all of them, verifying that outputs meet agreed parameters. On the exam, listen for words like continuous parameters and ongoing verification. If it's a one-time audit, it's not DQM. If it's a repeating process for maintaining quality thresholds, that's data quality management. Question 7. A health information director audits physician documentation and discovers that several discharge summaries from the past 6 months were finalized well beyond the regulatory completion window following each patient discharge from the acute care facility, which a HIPAA data quality characteristic has been compromised. Your options are A. Accuracy, B. Granularity, C. Comprehensiveness, D. Timeliness. Don't overthink it. Which one feels right? The correct answer is D. Timeliness. D is correct because timeliness requires that documentation be completed within a defined regulatory time frame, and discharge summaries finalized far beyond the standard 30-day window directly violate this critical HIPAA data quality dimension. A is wrong because accuracy refers to data being free from error, not whether documentation was completed within a regulatory time frame such as the 30-day discharge summary window required after patient discharge from the facility. B is wrong because granularity addresses how detailed each data element is and whether it can be subdivided further into smaller units, not whether documentation is completed within a required regulatory time frame after discharge. C is wrong because comprehensiveness addresses whether all required data items are present in the record, not whether the documentation was finalized within the regulatory time window that applies after a patient discharge from the inpatient facility. Let's talk about timeliness, one of the core data quality characteristics and one the exam loves to test. Timeliness measures whether information was captured, completed, or made available within a required window. In healthcare, that window is usually set by a regulator, not the organization itself. A history and physical must be in the record within 24 hours of admission, an outpatient visit note within 72 hours, a discharge summary within 30 days. Timeliness is simply hitting those deadlines. Be careful. Timeliness is easy to confuse with currency and accuracy. Currency asks if the content is the most recent version. Accuracy asks if it's correct. Timeliness asks only whether it arrived on schedule. When you see words like without, deadline, window, or a specific number of hours or days, the answer is timeliness. Question 8. A data analyst is designing a daily census report where each individual patient counts as one indivisible unit of data and cannot be broken into any smaller part for the purpose of the specific reporting requirement. Which HIPAA data quality characteristic best matches this design? Your options are precision, B. Granularity, C. Definition, D. Currency. Got a guess? Lock it in. The correct answer is B. Granularity. B is correct because granularity refers to data atomicity, meaning the individual data elements cannot be subdivided further, which matches a daily census where one single patient equals one indivisible unit of data. A is wrong because precision relates to numerical exactness in measurements such as size, weight, or other standards, not the indivisibility of an individual data element such as one single patient on a daily census report. C is wrong because definition refers to having clear meaning and acceptable values for each data element through tools like a data dictionary, not the indivisible atomic nature of a single data unit on a census. D is wrong because currency addresses how up-to-date the information is at a given moment in time, not the indivisibility of a single data element such as one patient counted on a daily census. Let's go deeper on granularity, one of the most commonly confused data quality characteristics on this exam. Granularity describes how finely a data element can be broken down. On a daily census, one patient is one indivisible unit. In a population health query, that same patient splits into age, sex, zip code, diagnoses, and encounters. Same patient, different granularity. Here is the distinction exam writers exploit. Granularity is about how small a piece of data can be. Precision is about how exact a number is. A weight measured to the 10th of a kilogram is more precise. A patient split into cohorts is more granular. Different dimensions entirely. The right granularity depends on the use case. Too coarse and the data cannot be filtered or grouped. Too fine and the report becomes noise. A census wants patients as units. A quality dashboard wants patients broken into cohorts. On the exam, watch for words like indivisible, atomic, smallest level of detail, or cannot be subdivided. Those all point to granularity. If the STEM is about decimal places or numerical exactness, pick precision instead. Question 9. A clinician treating a hospitalized patient needs the most up-to-date diagnosis information because the admitting diagnosis often changes by the time the patient is ready to be discharged from the inpatient unit. Which a HIPAA data quality characteristic is being emphasized? Your options are A. Currency, B. Relevancy, C. Accuracy, D. Consistency. Which one is it? Pause the video if you need more time. The correct answer is A. Currency. A is correct because currency refers to data being the most up-to-date version available, which directly matches the clinician needing a current diagnosis, since admitting diagnoses commonly change by the discharge date. B is wrong because relevancy addresses whether data is useful and applicable for the current purpose or specific patient encounter, not whether the diagnosis itself reflects the most recent or updated information available at the moment. C is wrong because accuracy refers to data being free from error and reflecting real-world facts correctly, not whether it represents the most current version of a diagnosis at the moment a clinician needs it for care. D is wrong because consistency refers to data remaining the same across different systems and over time without contradiction, not whether the information represents the most up-to-date version of a clinical diagnosis available. Let's talk about currency, the data quality characteristic that asks one simple question. Are you looking at the most up-to-date version available? Currency gets confused with timeliness and accuracy, but the distinctions matter. Timeliness asks whether data arrived within a regulatory window. Accuracy asks whether content is free from error. Currency asks whether you're seeing the most recent version. All three can fail independently. Picture an inpatient on day 4. The admitting diagnosis was chest pain, but by day 2 the workup was negative and the working diagnosis became gastritis. If the chart still shows the admitting diagnosis at the top, currency has failed, and the clinician is working with stale data. The mechanism behind currency is version control and time stamping. Every data element carries a time of entry, a time of update, and the last user who touched it. Clinicians default to the most recent value unless they deliberately navigate into history. On the exam, watch for signal words like most recent, latest version, or current. When the question asks which characteristic covers freshness, pick currency every time. Question 10. A hospital pharmacy team is implementing barcode scanning during medication dispensing as a way to reduce wrong dosage entries and prevent errors that could occur during the medication order entry process by clinicians. Which HIPAA data quality characteristic does this directly target? Your options are A. Timeliness, B. Granularity, C. Accuracy, D. Definition. Take a second. Which answer would you pick? The correct answer is C. Accuracy. C is correct because accuracy refers to data being free from error and the goal is reduction in mistakes. and barcode scanning during medication dispensing directly reduces wrong dosage entries during clinical order entry. A is wrong because timeliness addresses whether data is recorded and made available at the right moment in time, not whether barcode scanning prevents errors in the medication dispensing process during clinical order entry workflows. B is wrong because granularity refers to the level of detail in a single data element and whether it can be subdivided further, not the prevention of dosage entry errors during the medication dispensing process by pharmacy staff. D is wrong because definition addresses whether each data element has a clear meaning and acceptable values defined for system users, not whether barcode scanning prevents wrong dosage errors during the dispensing of medications. Let's dig into accuracy, the data quality characteristic that connects directly to patient safety and financial integrity. Accuracy asks whether the recorded information matches the real-world fact. In healthcare, a wrong answer can mean a wrong dose, a wrong surgical site, or a denied claim. Accuracy is often confused with validity. Validity just asks if a value is in the allowed range. A blood pressure of 120/80 is valid even if the patient's real reading was 160/90. Validity can pass while accuracy fails. Accuracy in clinical systems is engineered into the workflow. Barcode medication administration scans the patient wristband and drug label, verifies the 5 rights, and halts if anything mismatches. That forcing function traces back to the 1999 report to err is human, which put data accuracy on the national agenda. On the exam, if the STEM mentions free from error, matches reality, or a control designed to prevent wrong entries, the answer is accuracy. A barcode scanner or forcing function is always an accuracy control. Question 11. A regional skilled nursing facility, an acute care hospital, and a public health agency all participate in an arrangement where data is pushed from each separate facility into one shared repository that all parties can access for retrieval. Which HIE model is described? Your options are a federated model, B, hybrid model, C, decentralized model, D, centralized model. Before I reveal it, which one do you think is right? The correct answer is D, centralized model. D is correct because the centralized model stores all data from participating facilities in one shared repository that everyone can access, which matches the arrangement of pushing data into a single accessible source. A is wrong because the federated model, also called decentralized, keeps data at the participating facility and uses a record locator service to find records, rather than storing all data together in one shared central repository. B is wrong because the hybrid model combines a record locator service with a partial central repository, with some data still residing on participant servers. Not all data centralized into one shared location accessible to every party. C is wrong because the decentralized model is another name for the federated model, where data remains stored at each participating facility and is queried as needed, rather than being pushed to one shared central repository. Let's look at the theory behind the centralized model of health information exchange, and why it became the first architecture most regional exchanges adopted. Picture one big warehouse. Every participant ships their data in. Hospitals, clinics, public health agencies, and every authorized user queries that same shared store instead of chasing down 12 separate sources. Each participant configures an interface that pushes records, labs, and admissions into the repository. The operator normalizes and indexes the data, then exposes it through one query portal, so a provider sees a single consolidated record across every contributing source. All 3 models answer the same question: where does the data live? Centralized stores it together. Federated leaves it at the source and queries on demand. Hybrid does some of both. trading off speed, governance, and data freshness. On the exam, watch for phrases like one shared repository, pushed from each facility, or one accessible source. A single destination for all participant data, that's the centralized architecture. Question 12. A regional health information exchange uses a record locator service as the focal point for any patient query, allowing source data to remain stored at the originating facility until a specific request is made by a participating provider in the network. Which model is this? Your options are A. Centralized model, B. Federated model, C. Hybrid model, D. Direct exchange model. What's your answer? Commit to one before I continue. The correct answer is B. Federated model. B is correct because the federated model, also called the decentralized model, uses a record locator service as the focal point for patient queries while data remains stored at the originating facility until requested. A is wrong because the centralized model stores all participating data together in one shared repository for access by all parties, rather than leaving data at originating facilities and querying through a record locator service when needed. C is wrong because the hybrid model combines both a record locator service and a partial central repository for some data, while a pure federated model leaves all the data at the source facility until queried. D is wrong because direct exchange is a method of pushing encrypted information from one trusted sender to another known recipient, not an architectural model that uses a record locator service to leave data at originating facilities. Let's dig into the theory behind the federated model of health information exchange and why it exists at all. The federated model works like a library card catalog. A record locator service knows where each patient's data lives, but the actual records stay home on the participant's own servers, fetched only when someone asks. Here's the flow. The provider asks the locator service, which returns pointers to the hospitals and clinics holding records. The requesting system then fans out live queries, and each source responds directly. No central database ever assembles the full chart. The trade-off is data sovereignty versus query performance. Participants keep full control over their data, which made this model politically viable where centralization stalled. The cost is slower queries that can fail if one participant's system is down. On the exam, if you see a record locator service, data remaining at the originating facility, or decentralized queries on demand, the answer is federated. Federated and decentralized mean the same thing. Question 13. An exchange architecture combines a record locator service with a partial central data repository, where some participant data resides centrally for fast retrieval and some remain stored on participant servers until queried by other organizations in the network. Which model is being described? Your options are a hybrid model, B. Centralized model, C. Direct model, D. Federated model. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Hybrid model. A is correct because the hybrid model combines the functionality of a record locator service with a centralized repository, leaving some data at participant servers and storing some centrally, which matches this mixed architecture. B is wrong because the centralized model stores all participating data together in one shared repository accessible to every party, and does not leave any portion of the data residing on individual participant servers until later queried. C is wrong because direct is an exchange method that securely pushes authenticated encrypted information between known parties, not an architectural model that combines a record locator service with a partial centralized data repository for storage. D is wrong because the federated model leaves all data stored at the originating facility and uses only a record locator service for queries, with no portion of the data stored in any central repository for fast retrieval. Let's look at why the hybrid model exists and how it blends two worlds of health information exchange. Hybrid exchanges emerge from operational reality. Large health systems wanted to keep data local, while smaller practices preferred the simplicity of a central store. A single exchange had to accommodate both, so the architecture did too. The three architectures form a spectrum. Centralized ships everything to a common store. Federated leaves everything at the source. Hybrid sits between, using a record locator service as its backbone while also routing some data through a central repository. The split usually follows data type. Demographics, medications, allergies, and labs often go central because clinicians query them constantly. Clinical notes, imaging, and sensitive records stay at the source, where storage costs and privacy governance are best handled locally. On the exam, watch for the combination. Federated uses only a locator. Centralized uses only a repository. When you see both a record locator service and a partial central store in one architecture, the answer is hybrid. Question 14. A primary care physician needs to securely send a patient summary directly to a known specialist using an authenticated, encrypted, push-based method over the internet without involving any regional data repository or query service in the transmission. Which exchange method fits? Your options are A. Query-based exchange, B. Consumer-mediated exchange, C. Direct exchange, D. Federated exchange. Which would you go with? Lock it in before the reveal. The correct answer is C. Direct exchange. C is correct because direct exchange is a simple, secure, scalable, standards-based method allowing trusted participants to push authenticated encrypted health information directly to known recipients over the internet without central repository involvement. A is wrong because query-based exchange allows providers to search for and discover accessible clinical sources on a patient across the network, not to push a patient summary directly to a single specific known recipient. B is wrong because consumer-mediated exchange gives patients access to, manage and direct their own health information online, not a way for one provider to securely send a patient summary directly to another provider. D is wrong because federated refers to an HIE architectural model that uses a record locator service for queries, not an exchange method for one provider to push encrypted clinical data directly to another known recipient. Let's zoom out and understand what direct exchange really is and why it matters in health information exchange. Direct exchange is essentially certified email for clinical information. The sender knows the recipient, encrypts the message, and pushes it straight across the internet. No central repository, no lookup service, no middleman database. Mechanically, two pieces make it work. A health information service provider, or HISP, acts as the trusted gateway that authenticates both ends and encrypts the message. Each provider has a validated direct address, and the message pushes from sender straight to recipient. On the exam, listen for three signals. The information is pushed rather than queried. The recipient is specifically known, and no central database is involved. That combination points squarely at direct exchange. So remember, when a provider sends specific information to a specific other provider over a secure, point-to-point channel, that's direct exchange. Question 15. A patient wants to manage personal health information online by aggregating records from multiple different providers into one place, much like managing personal banking finances through an online portal where the patient controls the activity. Which exchange method best supports this? Your options are A. Direct exchange, B. Consumer-mediated exchange, C. Query-based exchange, D. Federated exchange. Don't overthink it. Which one feels right? The correct answer is B, consumer-mediated exchange. B is correct because consumer-mediated exchange gives patients direct access to their health information across providers so they can manage their own healthcare online, much like they manage personal finances through online banking. A is wrong because direct exchange is used for trusted providers to push authenticated, encrypted information to one another over the internet, not for patients to aggregate and manage their own health records across multiple different providers online. C is wrong because query-based exchange is used by providers to search for and discover accessible clinical sources on a patient, not by patients themselves to manage and aggregate their own health data across multiple providers. D is wrong because federated refers to an HIE architectural model that uses a record locator service for provider queries, not an exchange method that allows patients to manage their own aggregated health information online directly. Let's step back and look at the bigger picture behind consumer-mediated exchange and why it represents a genuine shift in how health information moves. Think of it as personal banking for your medical data. Just as you log into a bank app to see balances and move money, the patient logs into a health portal, pulls their records, and directs them wherever their care needs them to go. Picture a diabetic patient with 3 providers across 3 systems. An aggregator app pulls labs, medications, and visits summaries from each portal, and the patient forwards that combined record to any new specialist they see. 3 pillars made this practical. The 21st Century Cures Act banned information blocking, FHR gave us a common data format, and certified patient access APIs, required since 2020, opened the door for apps to actually pull the data. So when you see online banking analogies or patient-controlled records flowing across providers, that's consumer-mediated exchange. The patient is the intermediary, and that control is the defining feature. Question 16. A physician practice is updating its electronic platform so that patients can create profiles, view their personal health information from remote locations, and check the doctor's open availability before requesting an in-person office visit appointment. Which portal feature is being described? Your options are A. Online visits feature, B. Medication tracking feature, C. Appointment reminders feature, D. Scheduling feature. Got a guess? Lock it in. The correct answer is D, scheduling feature. D is correct because the scheduling feature is the patient portal capability that lets patients view a doctor's open availability so they can coordinate their personal calendar and request an office visit appointment online. A is wrong because the online visits feature refers to virtual care interactions delivered through the portal between patient and provider, not the ability to view a doctor's open availability and request an in-person visit appointment. B is wrong because the medication tracking feature refers to the portal capability that lists current medications, dosages, and refill status for the patient, not the ability to see a doctor's open times for an office visit. C is wrong because appointment reminders are automated notifications sent to patients about upcoming visits that have already been booked into the schedule, not the ability to view open availability before requesting a new visit. Let's talk about why the scheduling feature exists and what makes it distinct from other portal tools. Scheduling emerged because patients who could book flights, restaurants, and salons online wondered why their doctor's office still required a phone call. Healthcare was slower to adopt this pattern because medical scheduling involves visit types, provider rules, and insurance checks. The portal is broader than any single feature. It's a controlled window into the electronic health record, with separate sections for history, results, medications, messaging, billing, and scheduling. Each one solves a different problem, and scheduling specifically handles coordination. On the exam, watch for these signals: viewing open availability, requesting a new office visit, or coordinating the patient's calendar with the doctor's schedule. These phrases point to scheduling. Scheduling is the booking feature. When the question describes viewing provider availability and requesting a new visit online, pick scheduling, not reminders or online visits. Question 17. A patient wants a personal tool to collect, track, and share past and current information about personal health, including uploading daily blood sugar readings, tracking allergies and medications, and managing personal appointments without provider control. Which patient-centered technology fits? Your options are A. Personal health record, B. Patient portal, C. Health information exchange, D. Electronic medical record. Which one is it? Pause the video if you need more time. The correct answer is A. Personal health record. A is correct because the personal health record is a tool patients use to collect, track, and share their own past and current health information, including uploaded data such as daily blood sugar readings. B is wrong because a patient portal is maintained and controlled by the provider organization and gives patients view access to provider-held records, rather than serving as a patient-controlled tool for tracking and uploading personal health data. C is wrong because health information exchange is the electronic sharing of records among healthcare organizations using nationally recognized standards, not a patient-controlled tool for individuals to track, upload, and manage their own personal health information. D is wrong because the electronic medical record is created and maintained by clinicians within one single healthcare organization for use during care delivery, not a patient-controlled tool for collecting and sharing personal health information online. Let's step back and look at what really defines a personal health record and why it stands apart from everything else in the patient data family. A personal health record is patient-owned, patient-maintained, and patient-controlled. The patient is the custodian. They decide what goes in, who sees it, and how it's used. Ownership is the defining line that separates it from a provider-held record. Here's the family. The electronic medical record belongs to one provider. The electronic health record is shared across a network. The patient portal is just a window into a provider's record. Only the personal health record is owned and controlled by the patient. What makes it powerful is scope. A personal health record holds self-reported data like daily blood sugar, exercise, and over-the-counter meds, plus consolidated records from every provider the patient has ever seen. Spat, wider than any single clinician's chart. So when the question describes a patient aggregating, uploading, or controlling their own data across providers, the answer is personal health record. Patient-owned, patient-maintained. That's the signal. Question 18. A rural family practice clinic partners with a cardiology group located in a large city to deliver real-time, web-based cardiology consultations to patients after the rural clinic installs the necessary remote examination equipment for virtual cardiac assessments. Which technology supports this? Your options are A. Patient portal, B. Personal health record, C. Telehealth, D. Health information exchange. Take a second. Which answer would you pick? The correct answer is C. Telehealth. C is correct because telehealth is an alternative method for engaging with providers and receiving care remotely, which matches a rural clinic delivering real-time web-based cardiology consultations through installed remote examination equipment. A is wrong because a patient portal gives patients online access to view portions of their provider-held electronic record, not the technology that enables real-time remote cardiology consultations through installed examination equipment between two clinics. B is wrong because the personal health record is a patient-controlled tool for tracking and managing personal health data, not the clinical technology used to deliver real-time consultations remotely between a rural and an urban specialty clinic. D is wrong because health information exchange covers the sharing of patient records among organizations using national standards, not the clinical technology used to deliver real-time remote consultations to patients through web-based cardiac examination equipment. Let's zoom out and talk about what telehealth actually is, because it's bigger than just video visits. Telehealth comes in 3 main flavors. Live video visits happen in real time. Store and forward sends images or data for later specialist review. And remote patient monitoring streams data from home devices like blood pressure cuffs or glucometers to a clinician dashboard. Here's the key distinction on the exam. Patient portals give access to records. Personal health records let patients manage data. Health information exchange moves data between organizations. Only telehealth actually delivers the care itself. Picture a rural clinic that can't recruit a cardiologist. A nurse operates connected exam equipment while a cardiologist in the city conducts the consult live. A day of travel becomes an hour down the road. So when the question describes a clinician evaluating or treating a patient across distance, whether by video, forwarded images, or connected devices, pick telehealth every time. Question 19. A patient is admitted to an acute care facility while traveling and cannot recall the exact insulin dosage being taken at home each day. The patient remembers being enrolled in a portal maintained by the regular primary care physician. Where is this dosage located? Your options are A. Appointment history section, B. Medication history section, C. Problem list section, D. Laboratory results section. Before I reveal it, which one do you think is right? The correct answer is B. Medication history section. B is correct because the medication history section of a patient portal contains current and past medications including dosages, route, and frequency, which is exactly where the patient would find the recorded insulin dose. A is wrong because the appointment history section lists past and upcoming visits with providers along with visit dates and times, not the specific dosage information for medication such as insulin that the patient takes at home daily. C is wrong because the problem list section contains active diagnoses and ongoing medical conditions affecting the patient, not the specific dosage details of medications the patient currently takes for managing those active conditions and diagnoses. D is wrong because the laboratory results section contains test outcomes such as glucose readings, lipid panels, and other lab data, not the medication dosage information that the patient is asking about during the unexpected admission. Let's step back and look at the bigger picture, how patient portals organize clinical information, and why medication history matters so much. A patient portal is divided into sections and each one holds a distinct slice of the record. Medications live in medication history. Diagnoses live in the problem list. Test values live in lab results. Visits live in appointment history. The medication history section isn't entered by hand. It's populated from provider order entry, electronic prescribing, and reconciliation performed at each visit. The patient sees exactly what the provider sees, and refill requests route back to the prescriber through the same list. The Joint Commission named medication reconciliation a national patient safety goal in 2005. After research showed most medication errors happen at admission, transfer, and discharge. Giving patients their own list is a safety tool. One more set of eyes to catch errors before the next transition. So on the exam, when a patient is looking up what they take at home, it's always medication history. Problem list holds diagnoses, labs hold values, appointments hold dates. Drugs and doses every time live in medication history. Question 20. A community hospital wants to electronically connect with other regional hospitals so that providers can access and retrieve patient clinical data when patients receive care across multiple sites in the area, supporting safe and more timely patient-centered care. Which technology enables this? Your options are A. Personal health record, B. Patient portal, C. Wearable monitoring device, D. Health information exchange. What's your answer? Commit to one before I continue. The correct answer is D. Health information exchange. D is correct because health information exchange is the electronic sharing of health-related information among multiple organizations following nationally recognized standards, which matches connecting regional hospitals to share clinical data across sites. A is wrong because the personal health record is a patient-controlled tool for collecting and sharing personal health data managed by the patient, not the technology that connects multiple hospitals to share clinical data among providers across sites. B is wrong because a patient portal connects one single patient to one provider's record system for personal access, not the technology that connects multiple regional hospitals to share patient clinical data with each other across sites. C is wrong because a wearable monitoring device collects biometric data from one single patient for remote tracking by a clinician, not the technology that connects multiple regional hospitals to share clinical data across different care sites. Let's zoom out and look at the bigger picture of how health information exchange actually works as infrastructure. HIE systems are built in one of three architectural models. Centralized pools data in one repository, federated keeps data at each source and queries on demand, and hybrid blends both approaches to balance speed with local control. Picture a regional exchange linking hospitals, physician practices, long-term care facilities, and public health agencies. When a patient discharged from one hospital later shows up at a competitor's emergency department, the physician queries the exchange and instantly sees the recent admission, discharge summary, and medications. This is what makes HIE architecturally unique. Patient portals, personal health records, and wearables all connect to a single patient. Health information exchange is the only one designed for organization-to-organization clinical data sharing. So, when an exam question describes multiple sites sharing patient data using nationally recognized standards, health information exchange is your answer. Question 21. A physician at an acute care hospital is preparing to perform a history and physical examination in accordance with the Centers for Medicare and Medicaid Services conditions of participation for an inpatient who was just admitted. Within what time frame must this be placed in the record? Your options are A. No more than 24 hours after admission, B. Within 48 hours prior to discharge, C. Within 72 hours prior to admission, D. At first contact with admitting staff. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. No more than 24 hours after admission. A is correct because the CMS conditions of participation require the history and physical examination to be completed and placed in the record no more than 30 days before or 24 hours after admission. B is wrong because the H&P must be placed in the record near the time of admission to guide initial treatment decisions, not within 48 hours prior to discharge when most of the inpatient care episode has already concluded. C is wrong because 72 hours prior to admission is outside the allowed regulatory window, since CMS allows the H&P to be performed up to 30 days before admission or completed within 24 hours after the patient is admitted. D is wrong because while early documentation is encouraged, the CMS rule specifically requires placement within 24 hours after admission, not simply at the very first point of contact with the admitting physician or other medical staff. Let's zoom out and understand the rule behind this question. When must a history and physical be placed in the patient's record? The CMS conditions of participation set the federal floor for hospitals billing Medicare and Medicaid. Buried inside is a precise rule. The H&P must be completed no more than 30 days before admission, or no more than 24 hours after. The H&P is the anchor document for the entire inpatient stay. It captures baseline condition, history, exam findings, and the initial plan. Every subsequent progress note builds on it. Two pathways satisfy the rule. Scheduled admissions can rely on a recent office exam within 30 days. Emergency or off-hours admissions get 24 hours after arrival to document a full H&P in the charts. 30 days before, 24 hours after. When the exam asks about the H&P window for inpatient admission, pick 24 hours and move on. Question 22. A health information professional is reviewing the post-discharge documentation requirements for an acute care setting where the discharge summary must include the final diagnosis and provide brief details about the patient's hospital stay. Within what window must the summary be completed? Your options are A. Within 60 days after discharge, B. Within 90 days after discharge, C. Within 30 days after discharge, D. Within 45 days after discharge. Which would you go with? Lock it in before the reveal. The correct answer is C. Within 30 days after discharge. C is correct because the completed discharge summary is required to be finalized within 30 days after the patient is discharged from the acute care facility and serves as the foundation for future treatment. A is wrong because 60 days exceeds the standard regulatory completion window for an acute care discharge summary, which must be finalized much sooner to support continuity of care, follow-up treatment, and timely reimbursement processing. B is wrong because 90 days is far beyond the required completion window for an acute care discharge summary and would delay critical clinical information needed for follow-up care after discharge from the hospital. D is wrong because 45 days is longer than the required regulatory window for completing an acute care discharge summary, which must be finalized within 30 days after the patient leaves the inpatient facility setting. Let's talk about why the discharge summary has the completion window it does, and how it fits into the bigger picture of hospital documentation. The discharge summary synthesizes the entire admission into one reviewable narrative. It captures why the patient came in, what happened, what was done, and where they go next. Each documentation type has its own timing rule. The H&P is due within 24 hours of admission, operative reports immediately after surgery, and progress notes continuously. The discharge summary sits at the end with a 30-day window. 30 days exists because every downstream clinician needs this document. The primary care physician, the home health nurse, the specialist evaluating a new symptom, none of them can wait months for a summary that protects continuity of care. 30 days is the outside deadline, not the target. Dictating within 2 to 3 days produces a better document. But on the exam, 30 days after discharge is always the answer. Question 23. A patient is preparing to undergo a scheduled gallbladder surgery, and the surgical team must verify the patient understands the diagnosis, the nature of the procedure, the associated risks, the available alternatives, and the right to opt out before signing. Which consent type is this? Your options are A. Implied consent, B. Informed consent, C. Consent to treatment, D. Notice of privacy practices. Don't overthink it. Which one feels right? The correct answer is B. Informed consent. B is correct because informed consent verifies the patient understands the diagnosis, the nature of the procedure, the associated risks and benefits, the available alternatives, and the right to opt out. A is wrong because implied consent applies in emergencies or routine situations where a patient's actions imply general agreement to care, not for a planned scheduled surgery requiring detailed discussion of specific risk and treatment alternatives. C is wrong because consent to treatment is a general agreement signed at admission to receive specific services from the facility, not the detailed informed agreement specifically required before undergoing a planned surgical procedure such as gallbladder surgery. D is wrong because the Notice of Privacy Practices explains how the facility uses and discloses protected health information under HIPAA rules, not the patient agreement specifically required before undergoing a planned surgical procedure like gallbladder removal. Let's go deeper on informed consent, what it actually is and why it's more than just a signature on a form. Informed consent is a conversation with 5 required elements. The patient must understand the diagnosis, the nature and purpose of the procedure, the material risks and benefits, the reasonable alternatives including doing nothing, and their right to refuse or withdraw at any time. Informed consent sits among 3 related document types. General consent covers routine admission care. Implied consent applies in emergencies. Only informed consent requires the specific risk and alternative disclosure before a significant procedure. The rules are strict. The physician performing the procedure, not a staff member, must lead the discussion. It has to happen before any sedation, and the signed form documents the conversation. It does not replace it. Informed consent is the conversation, not just the signature. When a question describes a planned procedure with all 5 elements discussed, informed consent is your answer. Question 24. A nurse is preparing chronological documentation about a patient's response to ongoing treatment during a hospital stay, recording observations, symptoms, and care interventions in date order so that the rest of the care team can follow along across the entire stay. Which document is this? Your options are A. Consultation reports, B. Operative notes, C. Discharge summary, D. Progress notes. Got a guess? Lock it in. The correct answer is D. Progress notes. D is correct because progress notes are chronological statements about the patient's response to treatment during a stay in a facility, including ongoing care, treatment, and therapeutic responses recorded over time by clinicians. A is wrong because consultation reports contain opinions from physicians with specialty training beyond general certification, such as oncologists, cardiologists, or dermatologists, not chronological notes documenting the daily patient response to ongoing inpatient treatment by the care team. B is wrong because operative notes describe the surgical procedure findings, the postoperative diagnosis, the specimens removed during surgery, and other procedure details, not chronological documentation of a patient's day-to-day response to ongoing inpatient treatment. C is wrong because the discharge summary provides a single brief overview of the entire hospital stay completed at the end, not chronological day-to-day documentation of treatment response made throughout the patient's inpatient hospital stay. Let's look at what progress notes actually are and why they matter so much in clinical documentation. Dr. Lawrence Weed introduced the SOAP format in the late 1960s to bring discipline to clinical documentation. It forces writers to separate what the patient reports, what the exam shows, what the clinician concludes, and what will happen next. Progress notes are distinct from other documentation. The H&P is the admission anchor. The discharge summary is the end of stay synthesis. Consultations carry specialist opinions, and operative notes describe surgery. Progress notes cover everything in between. A good progress note captures what changed, what was done, and what will happen next. Beyond clinical use, these notes are often the only record of a clinician's real-time thinking, making them critical legal protection in malpractice cases. When the question describes chronological, day-by-day documentation of response to treatment during a hospital stay, the answer is progress notes. Question 25. A nurse needs to document that a patient received a single oral dose of an anticoagulant medication while hospitalized, including the drug name, dosage, route of administration, and time of administration for the official medical record entry. Where should this be recorded? Your options are A. Medication administration record, B. Nursing progress notes, C. Nursing flow sheet, D. Physician order section. Which one is it? Pause the video if you need more time. The correct answer is A. Medication administration record. A is correct because the medication administration record is maintained by nursing staff for all patients and includes drug name, dosage, route, and time of administration, updated each time a patient receives a dose. B is wrong because nursing progress notes capture chronological clinical observations, patient symptoms, and responses to treatment over time, not the structured details such as drug name, dosage, route, and exact time of every single medication dose administered. C is wrong because the nursing flow sheet records vital signs, intake and output, and routine clinical measurements collected over time during the stay, not the structured drug name, dosage, route, and administration time data for each medication dose. D is wrong because the physician order section contains written or verbal requests for medications, treatments, and procedures from the ordering physician, not the nursing documentation confirming that a specific dose was actually given to the patient. Let's zoom out and understand why the medication administration record exists and how it fits into the bigger picture of patient safety. The MAR is the structured nursing record that proves an ordered medication was actually given. It captures the drug, the dose, the route, the exact time, and the identity of the nurse who administered it, serving as both a clinical safety tool and a legal record. The MAR is easy to mix up with three neighbors. Physician orders are where the drug is prescribed. Progress notes are free text observations. Flow sheets track vitals and routine measurements. Only the MAR documents each dose given. Modern electronic MARs add barcode scanning at the bedside. The system cross-checks patient, drug, dose, route, and time against the active order. Any mismatch halts the workflow, which has dramatically reduced errors, especially with look-alike, sound-alike drugs. So whenever a question describes documenting the drug, dose, route, and time given to a patient, the answer is the medication administration record. Question 26. A new health information professional is learning about the federal law that established national standards for the protection of patient health information, set rules for electronic transactions, and created safeguards for privacy and security across the healthcare industry. Which federal law is described? Your options are A. Patient Safety Quality Improvement Act, B. Health Insurance Portability Accountability Act, C. Health Information Technology Economic Act, D. Affordable Care Act. Take a second. Which answer would you pick? The correct answer is B. Health Insurance Portability Accountability Act. B is correct because HIPAA, the Health Insurance Portability and Accountability Act, passed in 1996, established national standards for protecting patient information, governing electronic transactions, and creating privacy and security safeguards across healthcare. A is wrong because the Patient Safety and Quality Improvement Act of 2005 protects providers who voluntarily report patient safety events, not the federal law that set national standards for patient health information privacy. C is wrong because the Health Information Technology for Economic and Clinical Health Act, also called HITECH, expanded HIPAA but did not originally establish the national privacy and security standards governing patient information protection. D is wrong because the Affordable Care Act of 2010 expanded health insurance coverage and reformed delivery systems, not the law that originally established national privacy, security, and electronic transaction standards for patient information. Let's zoom out and see why HIPAA sits at the center of health information law. Passed in 1996, HIPAA did far more than its name suggests. It established national standards for privacy, security, and electronic transactions, the foundation for every modern rule governing protected health information. HIPAA is often confused with 3 other federal laws. HITECH expanded HIPAA's enforcement. The Patient Safety Act protects adverse event reporting. The Affordable Care Act reformed coverage. But only HIPAA created the national privacy and security standards. Remember HIPAA by its 3 pillars: the privacy rule governing how protected health information is used, the security rule safeguarding electronic records, and uniform electronic transaction standards that streamlined healthcare administration. So when the exam asks which federal law established national healthcare privacy and security standards, the answer is always HIPAA. Question 27. A health information manager is training new staff on what counts as protected information under federal privacy law. The training focuses on individually identifiable health information that is created, received, maintained, or transmitted by a covered entity. Which term describes this? Your options are A. Personally identifiable information, B. Sensitive personal data, C. Confidential medical record, D. Protected health information. Before I reveal it, which one do you think is right? The correct answer is D. Protected health information. D is correct because protected health information, also known as PHI, includes any individually identifiable health information that a covered entity creates, receives, maintains, or transmits in any form, whether oral, electronic, or paper. A is wrong because personally identifiable information is a broader privacy term used outside the healthcare context, not the specific HIPAA category for individually identifiable health data created or transmitted by a covered entity. B is wrong because sensitive personal data is a general data protection term, not specific to the healthcare industry, while HIPAA uses the precise term protected health information for this kind of regulated patient data. C is wrong because confidential medical record is informal phrasing rather than the formal legal HIPAA term, which is protected health information and applies to any media form, including oral, electronic, or paper formats. Let's unpack why protected health information has such a precise definition under HIPAA and what separates it from related privacy terms. PHI requires 3 things at once. It must be health information, it must be linked to an individual, and it must sit within a HIPAA-covered entity. Miss anyone, and the data simply isn't PHI. HIPAA names 18 specific identifiers, from names and dates to IP addresses and biometrics. Link any of these to health information and it becomes PHI. Strip all 18 away and the data is considered de-identified. Don't confuse PHI with its lookalikes. PII is broader and crosses all industries. Sensitive personal data belongs to European frameworks like GDPR. Confidential medical record is informal language. Only PHI is the precise HIPAA term. So when a question describes identifiable health data held by a covered entity, choose protected health information. That combination is the definition HIPAA actually regulates. Question 28. A privacy officer is identifying which organizations must directly comply with HIPAA privacy and security rules. The list should include healthcare providers who transmit electronic data, health plans, and healthcare clearinghouses that process billing and claims information. What term describes this group? Your options are A. Covered entities, B. Business associates, C. Trading partners, D. Authorized users. What's your answer? Commit to one before I continue. The correct answer is A. Covered entities. A is correct because covered entities are the three groups directly bound by HIPAA rules, including healthcare providers who transmit electronic transactions, health plans paying for care, and healthcare clearinghouses processing billing data. B is wrong because business associates are organizations that handle protected health information on behalf of a covered entity, such as billing companies or IT vendors, not the three primary groups directly bound by HIPAA. C is wrong because trading partners is a general industry term for organizations that exchange electronic data, not the specific HIPAA term for the providers, health plans, and clearinghouses directly subject to the rule. D is wrong because authorized users are individuals granted specific access rights to information systems, not the regulatory category that describes which types of organizations must comply directly with HIPAA privacy and security rules. Let's talk about covered entities, the three categories of organizations that HIPAA directly regulates. Providers generate health data, plans pay for care, and clearinghouses translate between formats. Congress picked these three in 1996 because they necessarily handle protected health information. Regulating them captures almost every legitimate custodian in the system. Picture a hospital, an insurer, and a clearinghouse. The hospital submits a claim electronically, the clearinghouse standardizes the format, and the insurer pays. All three are directly bound by HIPAA's privacy, security, and breach notification rules. Business associates like billing companies or cloud vendors handle PHR on behalf of covered entities. They're bound through agreements, not direct registration. And remember, a provider only becomes a covered entity when they transmit health information electronically in a standard transaction. When the exam asks who HIPAA directly regulates, pick the three: providers who transmit electronically, health plans, and healthcare clearinghouses. Question 29. A clinic billing clerk is requesting access to patient records to complete the daily claims processing tasks. Under HIPAA, the clerk should only access the patient information actually needed to perform that specific job function. Which HIPAA standard governs this requirement? Your options are A. Need to know rule, B. Right of access, C. Minimum necessary standard, D. Authorized disclosure rule. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Minimum necessary standard. C is correct because the minimum necessary standard requires covered entities to limit access, use, and disclosure of protected health information to only what is needed to accomplish the intended purpose or job function. A is wrong because need to know is a general security access principle used across many industries, not the formal HIPAA standard, which uses the specific term minimum necessary for limiting use of protected health information. B is wrong because the right of access is a HIPAA provision, giving patients the right to inspect or obtain copies of their records, not the standard that limits how staff access patient data. D is wrong because authorized disclosure rule is not the official HIPAA term, while HIPAA refers to restricting workforce access to only the protected information required for a specific job task as minimum necessary. Let's unpack the minimum necessary standard, the HIPAA rule that turns privacy from an abstract ideal into a concrete, everyday constraint. The rule says covered entities must use, disclose, and request only the protected health information needed for a specific purpose. Without it, lawful general access could drift into unlawful curiosity, like a receptionist peeking at a celebrity's discharge summary. Minimum necessary is easy to mix up with lookalikes. Need to know is a general security principle. Right of access belongs to patients. Authorization is a signed form. Only minimum necessary is the specific HIPAA limit on how much PHI moves in legitimate workflows. In practice, minimum necessary is enforced through role-based access controls, technical limits and training. A billing clerk sees codes and charges. A medical assistant sees scheduling and limited clinical data. The EHR enforces these boundaries and audit logs catch anyone who strays. On the exam, watch for phrases like limit access, only information needed, or specific job function. When a question describes restricting workforce access to exactly what the role requires, the answer is the minimum necessary standard. Question 30. A hospital is contracting with an outside billing company that will handle protected health information on the hospital's behalf to process claims. HIPAA requires a written agreement that holds the vendor accountable for safeguarding the data. What is this agreement called? Your options are A. Notice of privacy practices, B. Business associate agreement, C. Authorization for disclosure, D. Memorandum of understanding. Which would you go with? Lock it in before the reveal. The correct answer is B. Business associate agreement. B is correct because a business associate agreement is the written contract HIPAA requires between a covered entity and any vendor handling protected health information, holding the vendor accountable for safeguarding the data. A is wrong because the notice of privacy practices is given to patients to explain how a covered entity uses and discloses their information, not a contract holding an outside vendor accountable for protecting data. C is wrong because an authorization for disclosure is a patient-signed form permitting release of specific protected health information for a stated purpose, not the contract a covered entity signs with a third-party vendor. D is wrong because a memorandum of understanding is an informal agreement between organizations on shared goals or general terms, not the specific contract HIPAA requires when a vendor will handle protected health information. Let's dig into why the business associate agreement exists and what makes it different from every other HIPAA document. A covered entity can't run modern healthcare alone. Billing, IT hosting, transcription, coding, all of it touches protected health information. The business associate agreement is the contract that extends HIPAA's rules to every vendor on the other end of that cord. The agreement does 4 things. It binds the vendor to safeguard the information, limits how they can use or disclose it, requires breach reporting back to the covered entity, and lets the covered entity terminate the relationship if the vendor violates the terms. Exams love to mix these up. The notice of privacy practices is patient-facing. An authorization is patient-signed. A memorandum of understanding is informal. Only the business associate agreement is the HIPAA-mandated contract between a covered entity and a vendor. Since the 2013 Omnibus Rule, business associates are directly liable too. So whenever the question describes a covered entity contracting with an outside vendor that will touch protected health information, the answer is the business associate agreement. Question 31. A coder at an acute care hospital is assigning codes that describe the patient's diagnoses, signs, symptoms, and reasons for the encounter. These codes use a standard system of 3 to 7 alphanumeric characters maintained for US use. Which classification system applies? Your options are A. ECTC, B. ECD-10 PCs, C. SAPAC, D. HCPCS Level 2. Don't overthink it. Which one feels right? The correct answer is A, ICD-10-CM. A is correct because ICD-10-CM, the International Classification of Diseases 10th revision, clinical modification, is the US system used to assign 3 to 7 character alphanumeric codes for patient diagnoses, symptoms, and encounter reasons. B is wrong because ICD-10 PCS is the procedure coding system used only in inpatient hospital settings to code services and treatments performed, not the system used to code diagnoses or reasons for an encounter. C is wrong because CPT, current procedural terminology, is maintained by the American Medical Association and used to report physician services and outpatient procedures, not patient diagnoses, symptoms, or the reasons for an encounter. D is wrong because HCPCS Level 2 codes report supplies, equipment, drugs, and services not included in CPT, such as wheelchairs and ambulance transport, not patient diagnoses or specific reasons for the actual patient encounter. Let's go deeper on ICD-10-CM, the backbone of diagnosis coding in American healthcare. ICD-10-CM codes are 3 to 7 alphanumeric characters covering diagnoses, signs, symptoms, injuries, and reasons for the encounter. The US adopted it in October 2015, jumping from about 14,000 ICD-9-CM codes to roughly 70,000. A massive leap in specificity. Each code follows a consistent logic. The first 3 characters set the category, works like E11 for type 2 diabetes. Characters 4 through 6 add cause, site, and severity. The 7th character captures encounter type, and laterality is baked in where it matters. The exam tests these 4 together, and the distinctions matter. ICD-10-CM is diagnoses everywhere. ICD-10 PCS is inpatient procedures only. CPT handles physician services and outpatient procedures. HCPCS Level 2 covers supplies, equipment, and drugs. So remember the signal. If the question describes coding diagnoses, signs, symptoms, or reasons for the visit across any setting, the answer is ICD-10-CM. Question 32. A hospital coder is assigning 7-character alphanumeric codes for procedures performed during an inpatient hospital stay. The codes describe the section, body system, route operation, body part, approach, device, and qualifier of each procedure performed. Which classification system applies? Your options are, or say, B, HIPAA Level 2. So ICD-10 PCS. D, SNOMED CT. Got a guess? Lock it in. The correct answer is C, ECT PCS. C is correct because ICD-10 PCS, the procedure coding system, is used in inpatient hospital settings to assign 7-character alphanumeric codes describing section, body system, route operation, body part, approach, device, and qualifier. A is wrong because CPT, current procedural terminology, is used to code physician services and outpatient procedures using 5-character numeric codes, not the 7-character alphanumeric codes used for inpatient hospital procedure documentation. B is wrong because HCPCS Level 2 uses 5-character alphanumeric codes for supplies, drugs, durable equipment, and services not included in CPT, not the 7-character alphanumeric codes used for inpatient hospital procedure reporting. D is wrong because SNOMED CT is a clinical terminology used to capture clinical findings, observations, and concepts in electronic health records, not a procedure coding system designed for inpatient hospital procedure billing or reporting. Let's look at what makes ICD-10 PCS unique among coding systems. It's not just another code list, or it's a construction kit. Most coding systems work like a dictionary. You look up the code you need, ICD-10 PCS is different. You build each code from scratch, choosing one value for each of the 7 character positions. Each of the 7 positions carries a specific meaning, section, body system, root operation, body part, approach, device, and qualifier. The coder picks one value at each position, and together they form a single 7-character code. The root operation is the trickiest position and the one exams love to test. 31 options exist in the medical and surgical section, each with a precise definition. Choose wrong and the whole code is wrong, even if every other position is right. Remember the signal, 7-character alphanumeric codes. Inpatient setting, built from section, body system, and root operation. That combination points to one system only, ICD-10 PCS. Question 33. A physician practice is billing for services delivered in the outpatient setting and needs to report procedures and services using a standardized code set maintained by the American Medical Association. The codes contain 5 numeric digits. Which classification system applies here? Your options are A. ICD-10 B. ICD-10 PCS C. HIPAA level 2 D. CT. Which one is it? Pause the video if you need more time. The correct answer is D. CPT. D is correct because CPT, current procedural terminology, is maintained by the American Medical Association and uses 5-digit numeric codes to report physician services and outpatient procedures for billing across many practice settings. A is wrong because ICD-10-CM is the diagnosis coding system used to report patient conditions, signs, symptoms, and reasons for healthcare encounters in all settings, not the procedure code set maintained by the AMA. B is wrong because ICD-10 PCS is used only to code procedures performed in inpatient hospital settings using 7-character alphanumeric codes, not the AMA maintained 5-digit numeric system used for physician outpatient services. C is wrong because HCPCS Level 2 is maintained by CMS and uses alphanumeric codes for supplies, equipment, and services not included in CPT, rather than the AMA maintained 5-digit code set for procedures. Let's dig into CPT, the coding system that powers outpatient billing across American healthcare. CPT stands for Current Procedural Terminology. It's maintained by the American Medical Association, uses 5 numeric digits, and reports physician services and outpatient procedures. CPT lives alongside 3 sibling systems: ICD-10 CM codes diagnoses, ICD-10 PCS codes inpatient procedures. HCPCS Level 2 covers supplies and drugs. CPT is the only one maintained by the AMA rather than a federal agency. CPT is organized into 3 categories. Category 1 holds the main procedure, codes coders use every day. Category 2 tracks quality measures. Category 3 covers emerging technology still proving its clinical value. Here's your exam shortcut. When you see the American Medical Association, 5 numeric digits, and outpatient or physician services together, the answer is CPT every time. Question 34. A medical billing specialist needs to report durable medical equipment, ambulance services, prosthetics, and supplies that are not included in CPT. The code set used is maintained by the Centers for Medicare and Medicaid Services for these specific items. What system is used? Your options are A. ICD-10 PCS, B. HCPCS Level 2, C. SNORMIT CT, D. LOIN. Take a second. Which answer would you pick? The correct answer is B. HCPCS Level 2. B is correct because HCPCS Level 2 is the alphanumeric code set maintained by Centers for Medicare and Medicaid Services to report durable equipment, ambulance services, prosthetics, supplies, and items not included in CPT. A is wrong because ICD-10 PCS is the procedure coding system used in inpatient hospital settings to code surgical procedures and treatments, not the CMS-maintained code set for supplies, equipment, prosthetics, or ambulance services. C is wrong because SNOMED CT is a clinical terminology used to record clinical findings, conditions, observations, and concepts in electronic records, not a billing code set for medical supplies, equipment, or ambulance transport services. D is wrong because LUINC is used to identify laboratory test, observations, and clinical measurements in a standard universal format, not the code set used to bill for durable equipment, prosthetics, or ambulance services. Let's go deeper on HCPCS Level 2, the code set that handles everything CPT leaves behind. Think of it this way. CPT captures what the doctor does during the visit. HCPCS Level 2 captures the wheelchair, the oxygen tank, and the ambulance ride that surround that visit. HCPCS Level 2 codes are 5 characters, starting with a letter from A through V, followed by 4 digits. That leading letter tells you the category: A for ambulance and supplies, F for durable medical equipment, J for injectable drugs, L for orthotics and prosthetics. CPT is maintained by the American Medical Association for Physician Work. HCPCS Level 2 is maintained by CMEs for supplies and services CPT does not cover. Outpatient claims often use both systems side by side. So on exam day, when you see durable medical equipment, ambulance, prosthetics, or injectable drugs, reach for HCPCS Level 2. Question 35. An informatics analyst is looking for a standardized clinical terminology that captures detailed clinical findings, observations, problems, procedures, and concepts within an electronic health record. The terminology is widely adopted internationally for clinical documentation. Which system best matches this description? Your options are A. SNOMED CT, B. LUINC, C. ICD-10 CM, D. HIPAA. Before I reveal it, which one do you think is right? The correct answer is A. SNOMED CT. A is correct because it's SNOMED CT, the systematized nomenclature of medicine clinical terms, is a detailed, standardized clinical terminology used internationally to capture clinical findings, problems, observations, procedures, and concepts inside an electronic health record. B is wrong because LUINC is a standard terminology for identifying laboratory, test, and clinical measurements in a uniform format, not a broad clinical terminology for documenting findings, problems, and procedures across all clinical domains. C is wrong because ICD-10-CM is a classification system designed for coding diagnoses and reasons for healthcare encounters in US settings, not a detailed clinical terminology for capturing findings, observations, and procedures in records. D is wrong because RxNorm is a standardized naming system for clinical drugs and medication products used by US health systems, not a clinical terminology for documenting findings, observations, problems, or clinical procedures and records. Let's go deeper on SNOMED CT, the international clinical terminology that powers detailed documentation in modern electronic health records. SNOMED CT contains over 350,000 concepts covering findings, observations, problems, and procedures. Unlike billing classifications, it preserves the full granularity of what clinicians actually document. SNOMED CT lives in a family of healthcare terminologies, each with a distinct role. ICD-10-CM classifies diagnoses for billing, LOINC identifies lab tests, and RxNorm names medications, but only SNOMED CT captures the full clinical picture. Technically, SNOMED CT is a graph. Each concept has a unique identifier and is a relationships that build a hierarchy. So a system that knows a patient has type 2 diabetes can automatically infer diabetes mellitus and endocrine disorder. Remember, when a question describes a broad, standardized terminology for detailed clinical documentation in the EHR, the answer is SNOMED CT. Question 36. A health information systems analyst is implementing a messaging standard that allows the different clinical and administrative systems within one single large hospital to exchange data such as patient demographics, lab results, and admission, discharge, and transfer events. Which standard is used? Your options are F here. B, CD, E, DCOM, D, HLC. What's your answer? Commit to one before I continue. The correct answer is D, HIPAA. D is correct because HL7, Health Level 7, is the messaging standard used to exchange clinical and administrative data such as patient demographics, lab results, and admission, discharge, and transfer events between hospital systems. A is wrong because FHIR is a new HL7 specification using web-based application programming interfaces and resources for modern data exchange, not the original messaging standard for hospital admission, discharge, and transfer events. B is wrong because CDA, Clinical Document Architecture, is an HL7 standard for exchanging structured clinical documents like discharge summaries and care plans, not the messaging format used for routine admission and transfer events. C is wrong because DICOM, Digital Imaging and Communications in Medicine, is the standard used for exchanging medical images such as X-rays, CT scans, and MRIs, not for routine admission, discharge, and transfer messages. Let's look at why HL7 version 2 became the messaging backbone inside hospitals. Before 1987, hospital systems couldn't share data. Labs couldn't send results to the floor, admissions couldn't notify pharmacy, and radiology couldn't update the medical record. HL7 v2 solved this with a simple pipe delimited message format any system could pass. Here's how it works. When a patient is admitted, the admission system generates an ADT message. The interface engine broadcasts it to every downstream system. Lab, pharmacy, radiology, and the EHR all get the patient's identity at once. One message synchronizes a dozen systems. 3 message types do most of the work. ADT carries admission, discharge, and transfer events. ORM carries orders from providers to departments. ORU returns lab results and observations back to the chart. So remember, CDA handles documents, FHIR handles modern web APIs, and DICOM handles imaging. But when the question describes real-time exchange of demographics, orders, results, or admission events between hospital systems, the answer is HL7v2. Question 37. A health IT vendor is building a modern application that allows mobile apps and third-party software to securely retrieve specific clinical data from electronic health records using web-based programming interfaces and modular resources. Which standard supports this use case? Your options are A. HL7v2, B. CDA, C. FHIR, D. DICOM. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. FHIR. C is correct because FHIR, Fast Healthcare Interoperability Resources, is the modern HL7 standard that uses web-based application programming interfaces and modular resources so mobile apps and third-party software can retrieve data. A is wrong because HL7v2 is the original messaging standard used for exchanging clinical and administrative messages between hospital systems, not the modern web-based standard designed for mobile applications and third-party software. B is wrong because clinical document architecture defines structured clinical documents like discharge summaries and continuity of care documents, not the modern web-based application programming interface standard for mobile or third-party software access. D is wrong because DICOM is the standard for exchanging medical images such as X-rays and MRI scans between imaging systems, not the modern web-based application programming interface standard for clinical data access. Let's go deeper on FHIR, the Fast Healthcare Interoperability Resources Standard. It's the framework behind nearly every modern healthcare app you'll encounter. FHIR breaks health data into discrete resources like patient observation and medication request. Apps fetch them over standard HTTP using the same patterns Twitter and Google use, with OAuth handling authorization just like a banking app. FHIR doesn't replace HL7 v2, CDA, or DICOM overnight. Those still handle legacy messaging, documents, and imaging. But new patient-facing apps, mobile tools, and cloud platforms are built on FHIR, and federal certification now requires FHIR patient access APIs in every certified EHR. Imagine a startup building a medication reconciliation app. It authenticates through OAuth, pulls medication request resources from the EHR's FHIR endpoint, and ships in days. That's the power of using the same web patterns developers already know. On the exam, when you see mobile apps, third-party software, RESTful design, or modular web-based access to clinical data, pick F5. It's the modern healthcare API standard. Question 38. A health information manager is sending a structured continuity of care document to another healthcare facility, including the patient's history, problem list, medications, and allergies in an XML-based format. Which HL7 standard is used to exchange the structured clinical document? Your options are A. FHIR, B. CDA, C. HL7v2, D. DICOM. Which would you go with? Lock it in before the reveal. The correct answer is B. CDA. B is correct because clinical document architecture, known as CDA, is the HL7 standard used to exchange structured XML-based clinical documents such as continuity of care documents containing problems, medications, allergies, and history. A is wrong because FHR is the modern HL7 standard for accessing discrete clinical data through web-based application programming interfaces and modular resources, not the standard for exchanging structured XML-based clinical documents. C is wrong because HL7v2 is the messaging standard used for routine event-based exchanges, such as admission, discharge, and transfer notifications, not the standard for sending structured XML-based continuity of care documents. D is wrong because DICOM is the standard for sharing medical imaging data such as X-rays, computed tomography, and magnetic resonance imaging studies, not the standard for exchanging structured XML-based clinical documents between facilities. Let's dig into CDA, the clinical document architecture, and why it exists alongside the other HL7 standards. HL7v2 moves event-based data between systems in real time, but some clinical content is inherently document-based. A discharge summary, a consult report, a care plan, these lose their coherence when fragmented into messages. So CDA keeps the whole document intact. Every CDA document follows the same pattern. A header carries metadata, and the body holds clinical sections, each with a narrative block for clinicians and a structured entry block with coded data for machines. That dual representation is CDA's superpower. CDA sits alongside its siblings, each specialized for a purpose. V2 handles operational messaging. FHIR handles modern web access. DICOM handles imaging, and CDA is the document-oriented member, with CCDA templates like the continuity of care document required for meaningful use. So on the exam, when you see structured clinical document, XML, or continuity of care exchange between facilities, the answer is CDA. Question 39. A health systems architect describes a level of interoperability where two systems exchange data. Both can interpret the meaning of that data correctly, and the receiving system can use the data the same way the sending system does. Which level is described? Your options are A. Semantic interoperability, B. Foundational interoperability, C. Structural interoperability, D. Organizational interoperability. Don't overthink it. Which one feels right? The correct answer is A. Semantic interoperability is correct because semantic interoperability is the level where systems exchange information, both interpret meaning correctly, and the receiving system can use the shared data in the same way the sending system intended. B is wrong because foundational interoperability is the basic level where one system simply exchanges data with another, with no requirement that the receiving system interpret or correctly use the meaning of the shared data. C is wrong because structural interoperability defines the format and structure of exchanged data so it can be parsed correctly, but does not require the receiving system to interpret the meaning of the data fields. D is wrong because organizational interoperability addresses governance, policy, social, and legal considerations for sharing data across multiple organizations, not the technical level where the receiving system can interpret and use shared data semantically. Let's zoom out and look at the bigger picture behind this question, the 4 levels of healthcare interoperability, and why semantics sits at the top. Foundational interoperability just delivers the data. Structural adds format and syntax so it can be parsed. Semantic adds shared meaning so the receiver uses the data as intended. Organizational wraps it all in governance and policy. Each level builds on the one below. Here's the core idea. Moving bytes isn't enough. Parsing structure isn't enough. Semantic interoperability requires that the meaning itself survives the trip between systems. Shared meaning requires shared vocabularies. LOINC codes identify exactly what lab test was run. RxNorm identifies exactly what drug is meant. SNOME-CT identifies exactly what condition is recorded. With these codes, ambiguity collapses and meaning travels intact. On the exam, when the question describes both systems interpreting and using data the same way, pick semantic interoperability. Foundational is just delivery, structural is just format, organizational is policy. Only semantic preserves meaning. Question 40. A hospital lab is sending electronic results to multiple receiving systems and needs a standard set of universal codes that uniquely identifies each laboratory test, observation, and clinical measurement so that all systems interpret the results consistently. Which standard supports this? Your options are A. SNOME-CT, B. RxNorm, C. LOINC, D. CPE. Got a guess? Lock it in. The correct answer is C. LOINC. C is correct because LOINC, logical observation, identifies names and codes, provides a universal code set that uniquely identifies laboratory tests, observations, and clinical measurements so receiving systems interpret the results consistently across organizations. A is wrong because SNOME-CT is a broad clinical terminology used to record findings, problems, observations, and procedures in electronic records, not the universal code set specifically used to identify laboratory tests and observations. B is wrong because ORAC's-norm is a standardized naming system for clinical drugs and medication products used across U.S. health systems, not the universal code set used for identifying laboratory tests and clinical observations. D is wrong because CPT is a procedure coding system maintained by the American Medical Association used to bill for physician services and outpatient procedures, not a code set for identifying lab tests and observations. Let's dig into LOENC, the universal standard that lets lab results travel between systems without losing their meaning. Before LOENC, every lab invented its own code for the same test. One lab wrote HbA1c, another HbA1c, another hemoglobin glycated, so humans had to manually map codes between every pair of systems. Every LOENC code is built from 6 named parts: component, property, timing, system, scale, and method. Together they pin down exactly what was measured, how, and on what specimen, and if any one part differs, it's a different code. LOENC lives in a family of standards, each with its own lane. SNORMED CT covers clinical findings, ORAC's-norm names drugs, ICD-10-CM classifies diagnoses for billing, and LOENC is specifically for laboratory tests, measurements, and observations. So when the exam describes a universal code set that uniquely identifies lab tests and measurements across every system, the answer is LOENC. Question 41. A hospital is implementing an electronic system that lets physicians directly enter orders for medications, laboratory tests, imaging studies, and treatments into the electronic health record. The system reduces handwriting errors and supports clinical decision support alerts. What is the system called? Your options are A. Electronic medication record, B. Health information exchange, C. Patient portal, D. Computerized provider order entry. Which one is it? Pause the video if you need more time. The correct answer is D. Computerized provider order entry. D is correct because computerized provider order entry, known as CPOE, is the electronic health record function letting physicians directly enter medication, lab, imaging, and treatment orders, reducing handwriting errors and supporting decision alerts. A is wrong because the electronic medication administration record documents that nursing staff actually gave a medication dose to a patient, not the electronic system used by physicians to enter orders for medications and tests. B is wrong because health information exchange is the electronic sharing of patient records among multiple healthcare organizations, not the order entry function used by physicians to place medication, lab, imaging, and treatment orders. C is wrong because a patient portal gives patients online access to view portions of their own provider-held records, not the order entry tool used by physicians inside the electronic health record system. Let's look at why computerized provider order entry became a cornerstone of modern hospital safety. CPOE is the system that lets prescribers enter orders directly into the electronic health record. Medications, labs, imaging, consults, diet, and nursing tasks all route electronically to the department that fulfills them, with no paper and no transcription step. CPOE emerged after the "to err is human" report identified medication errors as a leading preventable harm. A typed order is unambiguous. A computer cannot mishear a verbal order, and direct entry eliminates transcription entirely. CPOE sits alongside several related components. The electronic medication administration record handles the nursing side. Clinical decision support layers alerts on 2 orders. The master patient index makes sure orders reach the right patient. Exam questions test whether you can tell these apart by what the user is doing. When the scenario shows a physician directly entering medication, lab, or imaging orders with real-time alerts, the answer is computerized provider order entry. Question 42. A hospital nurse needs to document each medication dose given to a patient, including the drug name, dose, route, and time, using barcode scanning to confirm the right patient and right medication at the bedside. What is this electronic system called? Your options are A. Computerized provider order entry, B. Electronic medication administration record, C. Clinical decision support system, D. Master patient index. Take a second. Which answer would you pick? The correct answer is B. Electronic medication administration record. B is correct because the electronic medication administration record, called EMAR, is the system nurses use to document each dose given by drug name, dose, route, and time, often confirmed at bedside via barcode. A is wrong because computerized provider order entry is the system physicians use to enter orders for medications, tests, and treatments, not the bedside documentation system nurses use to record each medication dose given. C is wrong because clinical decision support delivers alerts, reminders, and evidence-based recommendations to clinicians during clinical care decisions, not the bedside system nurses use to record each medication dose with barcode confirmation. D is wrong because the Master Patient Index is a database that uniquely identifies each patient across all systems in a healthcare organization, not the bedside system used to record nursing administration of medication doses. Let's dig into the theory behind the EMAR and why it sits at the heart of modern medication safety. The electronic medication administration record documents every dose given to a patient. It captures the drug, the dose, the route, the time, and the identity of the nurse who gave it, replacing the old paper grid of times and initials that had no real audit trail. Here's how the closed loop works in practice. The nurse pulls the due medication, scans the patient's wristband, then scans the drug label. The system checks both against the active order, and only after a match does the administration get recorded with a timestamp. The EMAR sits alongside three other core electronic health record functions. CPOE is where the physician enters the order. Clinical decision support fires alerts during ordering. The Master Patient Index links identity across systems. The EMAR is specifically the nursing side, documenting that each ordered dose was actually given. So when a question describes a nurse documenting each dose at the bedside with barcode scanning, the answer is always the electronic medication administration record. Question 43. A hospital is adding a feature to the electronic health record that delivers real-time alerts to clinicians about drug interactions, allergy warnings, and evidence-based recommendations during the order entry and clinical documentation process. What is this feature called? Your options are A. Clinical decision support, B. Computerized order entry, C. Medication administration record, D. Patient portal access. Before I reveal it, which one do you think is right? The correct answer is A. Clinical decision support. A is correct because clinical decision support delivers real-time alerts, reminders, drug interaction warnings, allergy notifications, and evidence-based recommendations to clinicians during order entry and documentation to improve patient safety overall. B is wrong because computerized order entry is the function physicians use to enter orders into the system, while decision support is the separate alert and recommendation feature that runs alongside it during entry workflows. C is wrong because the medication administration record is the system nurses use to document each medication dose given to a patient, not the alert and recommendation feature delivering drug interaction warnings to clinicians. D is wrong because the patient portal gives patients online access to view portions of their own provider record, not the clinician-facing alert and recommendation feature delivered during order entry and clinical documentation workflows. Let's look at the theory behind clinical decision support, the alerting layer that keeps clinicians safe in real time. Clinical decision support turns the passive medical record into active guidance. It fires alerts for drug interactions, allergy conflicts, dose errors, and missed preventive services, right at the moment a clinician is making a decision. It's important to distinguish CDS from the systems it runs alongside. CPOE is where orders are entered. The EMA documents nursing administration. The Master Patient Index handles identification. CDS is the alerting layer that operates across all of them. CDS ranges from simple to sophisticated. A basic allergy alert fires on a known allergy. An interaction check ranks conflicts by severity. A guideline reminder prompts preventive services like cancer screenings when a patient meets criteria. So on exam day, when you see real-time alerts, drug warnings, or evidence-based recommendations during clinical work, the answer is clinical decision support. Question 44. A health information manager needs a database that uniquely identifies every patient across the healthcare organization, links all medical record numbers and encounters to one identity, and prevents duplicate records when patients receive care across different facilities. What is this database called? Your options are A. Electronic health record, B. Health information exchange, C. Clinical data warehouse, D. Master patient index. What's your answer? Commit to one before I continue. The correct answer is D, Master Patient Index. D is correct because the Master Patient Index is the database that uniquely identifies every patient across an organization, links record numbers and encounters to one identity, and prevents duplicate records across different facilities. A is wrong because the electronic health record contains the actual clinical content for each patient encounter, not the indexing database that uniquely identifies each patient and links all of their record numbers together. B is wrong because Health Information Exchange is the technology that shares records across multiple healthcare organizations, not the indexing database used inside one organization to uniquely identify patients and prevent duplicate medical records. C is wrong because a clinical data warehouse aggregates large volumes of historical clinical data for reporting and analytics, not the indexing database used to uniquely identify each patient across the entire organization environment. Let's dig deeper into the Master Patient Index, the quiet infrastructure that makes a health system function as one organization rather than a dozen disconnected silos. The MPI uniquely identifies every patient across the organization and links all of their record numbers, encounters, and clinical data to one enterprise identity. It exists because the United States never implemented a national patient identifier, so every health system must solve identification locally. Picture a regional health system with an academic medical center, community hospitals, and ambulatory clinics. When a patient arrives at a new site, the MPI matches their demographics to the existing identity. So the physician opens one chart containing the full history from every facility. The MPI sits alongside other EHR components but plays a distinct role. The electronic health record holds clinical content. The Health Information Exchange shares data across organizations, and the clinical data warehouse powers analytics. But only the MPI is the identification database underneath them all. So when a question describes uniquely identifying patients and linking all their medical records across an organization, the answer is the Master Patient Index. Question 45. A clinician is updating an active list of all the patient's current medical conditions, diagnoses, and ongoing health concerns inside the electronic health record, so the entire care team can see what the patient is being treated for. What is this list called? Your options are A. Allergy list, B. Medication history, C. Problem list, D. Encounter log. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Problem list. C is correct because the problem list is the active list inside the electronic health record that captures the patient's current medical conditions, diagnoses, and ongoing health concerns for the care team to view. A is wrong because the allergy list documents the patient's known drug, food, and environmental allergies and the type of reaction, not the active list of current medical conditions, diagnoses, and ongoing health concerns. B is wrong because medication history captures current and past medications including dose, route, and frequency, not the active list of medical conditions, diagnoses, and ongoing health concerns the entire care team is treating. D is wrong because the encounter log records each visit, admission, or interaction the patient has with the healthcare organization, not the active running list of current medical conditions, diagnoses, and ongoing health concerns. Let's go deeper on the problem list and why it sits at the heart of every modern electronic health record. Think of the problem list as the patient's clinical dashboard. It's the running list of active diagnoses and ongoing concerns the care team is monitoring, while resolved issues get archived to an inactive list for history. The exam loves to test this side by side. The allergy list tracks reactions. The medication history tracks drugs. The encounter log tracks visits. Only the problem list tracks the active medical conditions being treated. A well-maintained problem list drives 3 downstream engines. Decision support rules fire against it. Care coordination uses it to assign registries, and population analytics aggregate it to find uncontrolled chronic disease. None of that works if the list is stale. So when the question describes the running list of current medical conditions, diagnoses, or ongoing health concerns the team is treating, pick the problem list every time. Question 46. A hospital billing department is being paid by Medicare for an inpatient hospital stay using a system that classifies patients into a single payment group based on diagnoses, procedures, age, gender, and discharge status. Which payment system is being described? Your options are A. MSDRG prospective payment, B. fee-for-service payment, C. capitated payment system, D. charge-based payment system. Which would you go with? Lock it in before the reveal. The correct answer is A. MSDRG prospective payment is correct because Medicare Severity Diagnosis Related Groups, or MSDRG, is the inpatient prospective payment system that classifies patients into one payment group based on diagnoses, procedures, age, gender, and discharge status. B is wrong because fee-for-service pays providers a separate amount for each individual service, test, or procedure delivered, not a single bundled payment based on classifying the stay into a payment group. C is wrong because capitated payment pays providers a fixed amount per patient per month, regardless of the services delivered, not a payment determined by classifying an inpatient stay into a specific diagnosis-related group. D is wrong because charge-based payment pays providers based on their individual billed charges for each service, not the prospective system that classifies an inpatient stay into a single bundled payment group for Medicare. Let's go deeper on MSDRGs and why this payment system exists in the first place. Before 1983, Medicare reimbursed hospitals based on actual costs. That created a perverse incentive. The longer the stay and the more services billed, the more the hospital earned. Here's the mechanics. The coder assigns ICD-10 diagnosis and procedure codes. A software grouper runs them through a decision tree, weighing the principal diagnosis, complications, and procedures, and outputs one DRG. that DRG maps to a relative weight which multiplied by the hospital's base rate gives the final payment. MSDRG is just one of several Medicare payment methodologies. APCs cover hospital outpatient services, the physician fee schedule covers professional services, and skilled nursing and home health each have their own prospective payment systems. Remember, MSDRG is the Medicare inpatient bundle. One stay, one payment group, one fixed amount, regardless of how long the patient stays. Question 47. A hospital outpatient department is being reimbursed by Medicare using a system that groups outpatient services into payment classifications based on similar clinical and resource needs, with a fixed payment amount per group regardless of actual cost. Which payment system applies? Your options are A. MSDRG inpatient payment, B. APC outpatient payment, C. Resource-based fee schedule, D. Per diem payment system. Don't overthink it. Which one feels right? The correct answer is B. APC outpatient payment. B is correct because ambulatory payment classifications, or APC, is the Medicare outpatient prospective payment system grouping outpatient services into payment classifications based on similar clinical and resource needs with a fixed payment. A is wrong because MSDRG is the prospective payment system used for Medicare inpatient hospital stays, classifying patients into payment groups based on diagnoses and procedures, not the system used to reimburse hospital outpatient services. C is wrong because the resource-based relative value scale fee schedule pays physicians for each individual service, not the outpatient prospective payment system that groups hospital outpatient services into bundled fixed payment classifications. D is wrong because per diem payment reimburses inpatient stays at a daily rate covering all services delivered that day, not the prospective system that bundles hospital outpatient services into payment classifications with fixed amounts. Now that we've identified APCs as the answer, let's understand how this payment system actually works under the hood. APCs power the outpatient prospective payment system, which took effect in August 2000. Similar services are grouped by clinical characteristics and resource needs, and Medicare pays one fixed amount per group, regardless of the hospital's actual cost. Here's the mechanics. Each service gets a CPT or HCPCS code, which maps to an APC group with a defined relative weight. That weight is multiplied by Medicare's annual conversion factor, adjusted for local wages, producing the hospital's payment. APCs sit alongside several other Medicare methodologies. MSDRGs cover inpatient stays. RBRVS pays physicians under the fee schedule, and skilled nursing facilities use their own acuity-based system. APCs apply specifically to hospital outpatient departments. So whenever the exam describes Medicare grouping hospital outpatient services into classifications with fixed payments, the answer is APC. Question 48. A primary care physician practice is paid by an insurance plan separately for every individual office visit, lab test, and procedure delivered to each patient, with the payment based on the specific service performed during each encounter. Which payment model is this? Your options are A. Capitation model, B. Bundled payment model, C. Value-based purchasing, D. Fee for service. Got a guess? Lock it in. The correct answer is D. Fee for service. D is correct because fee for service is the traditional payment model where providers are paid a separate amount for every individual office visit, lab test, and procedure delivered to each patient per encounter. A is wrong because capitation pays a provider a fixed monthly amount per patient per month to cover all needed care, regardless of how many individual services are actually delivered during the contract period. B is wrong because the bundled payment model pays a single fixed amount that covers all services related to one episode of care, such as a knee replacement, not separate payments for every individual service. C is wrong because value-based purchasing ties payment to clinical outcomes and quality measures rather than the total volume of services provided, not the traditional model paying separately for each individual service delivered. Let's zoom out and look at the bigger picture behind this question, how American healthcare actually pays providers. Fee-for-service works like paying a mechanic for each individual part they replace. Every office visit, every lab, every imaging study, every procedure generates its own separate bill and its own separate payment. Fee-for-service sits at one end of a spectrum. Capitation pays per patient per month. Bundled payment covers a whole episode of care. Value-based purchasing ties payment to outcomes. Each model creates a different incentive for providers. Mechanically, every service gets a CPT code. The provider submits a claim with diagnosis codes, and the payer adjudicates it against a fee schedule. This cycle repeats across millions of encounters every single day. So when you see a practice billed separately for each visit, test, and procedure, that's fee for service. Pay per service, every unit of work, every time. Question 49. A health system is being reimbursed by Medicare using a model that ties payment to measurable patient outcomes, clinical quality measures, and patient satisfaction scores rather than to the total volume of individual services delivered. Which reimbursement approach is this? Your options are A. Fee for service, B. Per diem payment, C. Value-based purchasing, D. Charge-based billing. Which one is it? Pause the video if you need more time. The correct answer is C. Value-based purchasing. C is correct because value-based purchasing ties Medicare payment to measurable patient outcomes, clinical quality measures, and patient satisfaction scores rather than the volume of individual services delivered by a hospital or provider. A is wrong because fee-for-service pays providers a separate amount for each individual service, test, or procedure delivered, with no link between payment and clinical outcomes, quality measures, or patient satisfaction scores. B is wrong because per diem payment pays a flat daily rate for inpatient services delivered each day of a hospital stay without linking payment to measurable patient outcomes, quality measures, or satisfaction scores. D is wrong because charge-based billing pays providers based on the actual charges they bill for each service delivered, not a model linking payment to measurable patient outcomes, clinical quality, or satisfaction scores. Let's dig into the theory behind value-based purchasing, a model that's reshaping how healthcare actually gets paid. Value-based purchasing ties reimbursement to measurable outcomes, clinical quality, and patient satisfaction scores. Providers earn bonuses or accept reductions based on how they perform, aligning financial incentives with quality rather than rewarding sheer volume of services delivered. Compare the major models, the exam tests together. Fee-for-service pays per service. Capitation pays per patient per month. Bundled payment pays per episode. Only value-based purchasing links payment directly to measured outcomes and quality. Here's how the mechanics work. Hospitals are scored on metrics like mortality, HCA/HPS satisfaction, and process compliance, then risk-adjusted and compared to national benchmarks. The composite score drives the payment adjustment. Top performers earn bonuses. Bottom performers see reductions. The bottom line, value-based purchasing pays for quality, not quantity. When a question describes payment tied to how well care performed rather than how much was delivered, that's value-based purchasing. Question 50. A managed care organization pays a primary care physician practice a fixed monthly amount per enrolled patient to cover all needed primary care services, regardless of how many visits, tests, or services each patient actually uses each month. Which model applies? Your options are A. Capitation, B. Fee-for-service, C. Bundled payment, D. Value-based purchasing. Take a second. Which answer would you pick? The correct answer is A. Capitation. A is correct because capitation is the managed care payment model where a provider receives a fixed monthly amount per enrolled patient to cover needed care, regardless of how many visits each patient uses. B is wrong because fee-for-service pays the provider a separate amount for each individual service, test, or procedure delivered, not a fixed monthly amount per enrolled patient regardless of services actually used. C is wrong because bundled payment provides one fixed amount covering all services related to a single episode of care, such as a knee replacement, not a fixed monthly amount per enrolled patient under managed care. D is wrong because value-based purchasing ties payment to clinical outcomes, quality measures, and satisfaction scores, not the managed care model paying a fixed monthly amount per enrolled patient regardless of services used. Let's zoom out and look at how capitation actually works as a payment model. Think of capitation like a gym membership in reverse. The provider is paid a flat monthly fee per enrolled patient, whether that patient shows up weekly or never walks in the door. Capitation sits at one end of a payment spectrum. Fee-for-service pays per service, bundled payment pays per episode, and value-based purchasing pays on outcomes. Capitation is the only model that pays a fixed amount per patient per month. Yes, Lawhorns, putting utilization risk squarely on the provider. Here's the math in practice. A primary care group with 3,000 enrolled patients at $60 per member per month earns $180,000 monthly, regardless of whether the month is busy or quiet. So remember, capitation is payment per head per month, fixed amount per patient, no matter the utilization.
You have reached the end of our first question set. For the free complete exam preparation, visit our website link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.